Thank you, organizers. Good morning, everybody. I'm so happy and honored to be here to share a little bit of story from our side regarding biomarker and anti-cancer immunomodulation, particularly from a smaller molecular perspective, how it works in the advanced stage of HBV-related HCC in cancer patients. So this is my COI statement. This is all my presentation, my personal view, knowledge, and understanding, and not intend to present from any corporation and a business unit, and no conflict interest to disclose from former employee or Novartis. So my outline here, three category or three parts. One is generally briefly introduce how HCC disease complexity look like. The second, talking about the immunotolerance of the HCC. And the third, brief introduce our phase 1, phase 2 trials linked to the immunomodulation of this small compound. So regarding the novel drug discovery, there are two most important dimensions we have to take care. One is to have better understanding of the disease for cancer patients. And this is one dimension. Second dimension is better to understand the drug action of mechanism or mechanism of action of drug. So this, without these two dimensions, the drug is hard to be deliverable to the patient. So here, example, the Novartis have a very famous Gleevec trial. So that's the story. Many people know that until that we found the target, found the BCR-ABL, the gene mutation, that the time point around 1999, and then triggered the trial to be successful and triggered the United States to be the precision medicine and target driving the clinical trial. However, the HCC and pancreatic cancer is not lucky as compared to the liquid cancers. Very, very little understanding about this disease. So that's why the liver cancer trials in the last 10 years that are quite often fail. The United States, the picture is here we see the across the different tumor types. The good news is top part, most of the solid tumors has been controlled or decreased the mortality in the last 10 years or 20 years. The bad news is the lymphoma, the melanoma and the liver cancer or pancreatic cancer have a little impact on the treatment. So that's a reason is why liver cancer is hard to be treatable, because we have little understanding about this disease. Even we have accumulated data to show the genes mutations as the list we show here. However, very few mutation or driver genes was able to transform into the druggable target. So TER2, P53, and many mutations in liver cancer, there are very, very few was able to deliverable. That is a challenge we are facing now. In terms of the liver cancer in China, there are many more particular challenges because of in China, they are covered almost half of the population of liver cancer and half of the population at the mortality, but they are more relevant to the HBV viral infection. About 90% of patients HCC linked to the HBV infection and with a high mortality, and it's particularly the poor prognosis. The outcome are not comparable to the rest of the other countries, HCC in general. So current treatment options, there are three. One is routinely sorafenib. This is approved by 2011 or 12. Now the chemotherapy of the 4-4. Then since last year, we have a patient available to access to the anti-PD-1. So that is what we are here today. Challenge is, even with that, we still have safety concern because of the higher rate of the AE, the advanced event, happen to the 3 to 4 stages. This is the most concern. Second, even if drug approved by the FDA or by China FDA, but it still have a limited efficacy and lack of the biomarker to lead the precision medicine to treat the right patient at the right time, even the first line or second line treatment. And more patients have a with prognostic risk, but we don't have optimal treatment options. The inflammation and the immune response are well documented in the many publications in the last 20 years. And here are receptors linked to downstream of the myeloid-derived and IgK and NF-kappa B. But these are very complicated immunoinflammation system, but they are linked to the release of cytokine factors from different types of immune cells. And liver cancer, we see they are from healthy liver, chronic HBV infection, or other different types of infection to lead to liver cancer mortality. They have a complicated biological processing. We should not only focus on genetic or epigenetic. We have to consider the inflammation and immunology. We learned this from last 3 or 5 years from liver cancer. And that's why we see the liver cancer, especially for advanced liver cancer, they are not talking about the liver cancer itself. We have combined together of a liver disease. They have HBV infection, chronic inflammation, liver injury, immune disorder, cirrhosis, and fibrosis, even metabolic disorders. So this is a very complicated disease. Here is an example that liver tissue paratumor monocyte, they have a well correlated studies, see the PD-L1 positive staining with HLA staining. You see the tumor environment immunocells, their expression have well correlated. And another study from China hospital that showed 10 years ago, you see that tumor tissue related to that T-cell infiltration, even Treg infiltration or CD8 infiltration, or the PD-L1 high expression profile, they are associated with poor prognosis, particularly for the post-surgery, their PFS or the OS or the recurrent. So this is from the epidemiology study to see the patient how it performs linked to the tumor immune environment. Here is another example of how the TME stroma cells, the high expression profile linked to poor prognosis in the Chinese patient. The top one is considering the stellate cell and the master cell. The bottom to show the neutrophil cells infiltration, higher infiltration and poor prognosis in this patient. And that's why we're considering the immuno or inflammatory tumor environment. They are very important, not only because of their dynamic change, but also they have a multiple level of this heterogeneity of the patient. Some patients have immuno-exhausted, some patients may be pre-existing immunity. So there are heterogeneity of the patients we have to consider for the clinical trial. The HBV infection is even also adding additional level of the challenging because they have a chronic infection, have an acute liver injury processing. They also have active, inactive, reactive, and exhaustion the cycle of the HBV in our body. So this is another challenge we're considering how we treat the patients when we have liver cancer. Now, when I see the liver cancer multiple tolerance or immunotolerance mechanism, I list here about 7 dimensions or 7 layers of the immunotolerance. HAFP is well known as the liver, more towards liver cancer specific immunotolerance mechanism. We're also considering the HBV infection and Treg and immunocells, neutrophil macrophage level, cytokine level, and the immune checkpoint level, and also the new antigen processing or the expression much lower than other solid tumor. So this is where we see the whole picture of the left side, the multiple level of the immunotolerance mechanism to make this liver cancer hard to treat. And if we look at the left side, we see that only the immune checkpoint inhibitors, even they are very complicated processing. Today, we're only talking about PD1, PD-L1, CDR4, but they are beyond our own understanding. So luckily, we do have a patient able to access to the PD1. We have BMS approved drug. We have Merck approved anti-PD1 drugs. We have a local Chinese company and 2 PD1 drugs available for the patient, and people considering the targeted therapy combination with the PD1. But the story is not ended. We still have a more complicated way to learn and to improve the patient outcome. Here is a list of the immune checkpoint inhibitors trials. The most trials, they are still active. However, they are not outcome, they are kind of less as we saw. The expectation is very high, we are, but this does not meet our patient or our clinicians' perspective. Why? Because most immune checkpoint inhibitors, they have a higher profile of a liver toxicity. That is because of liver and organ, they are very unique, very fragile. And this is one of the reasons liver toxicity is a higher priority to consider. Here is a distribution of the immune-related AE, the CTLA-4, PD-1, PD-L1 distribution. You see the GI, the skin, and the liver. They are very common to be the grade 2, grade 3, grade 4, the AE. Here we listed the grade 3 to grade 5 AE distribution to these organs. So this is where we have to pay attention to our future drug development. Well, here is a listing of the HBV versus non-HBV liver cancer trial with PD-1 data. We see some trend of the HBV in terms of 51 patients compared to the non-HBV HCV patient 50. Their outcome, including PR, SD, and progression disease, a little bit different. So that is why we often, when we design a trial, we have to separate that populations and demographic differently. Another reason is that most of the trials so far in the HCC, they are never in PD1 list, between 15 to 20% response rate. There are most patients, they are still not responsible well, or even progression, or hyper-progression, or pseudo-progression. And this is a challenging for PD1 to treat the HCC patient. Now, we have delivered here the Icaritin. This is more well documented for small molecule immunomodulation. And in last 10 years, we have accumulated 1,000 papers regarding this small molecule. But we do deliver transforming to this research to the clinical trial in liver cancer. And this is a 2015 Nature Review put our Icaritin as the first immunomodulator as example to show that encouraging the small molecule immunomodulation might be very important for liver cancer. And around the last years, there are many review papers to show that big opportunities of small molecule for the immuno-oncology. And that's encouraging us to continue our phase 2, phase 3 study. Now, here is why we consider small molecule compared to the big molecule or protein-based therapy. Here I listed about 6 categories of the advantage. First, there are higher cell permeability and organ specificity, and oral administration. That's obviously an advantage, and a unique, suited for the intracellular target. That's the big molecule or PD-1 or the large molecule cannot be able to compare. And equal applicable to cell surface and extracellular target, and maybe uniquely to treat the viral infected cancer patient. Here we see HBV-related HCC. The viral infection to the different organ and different disease, and we maybe use the HBV HCC as a model to project the next 10 years about the coronavirus we link to the many different diseases. The HBV liver cancer is a very good model to learn, to dig out the mechanism and the immune disorder and how treatment. Here is an example how the small molecule, we published this paper in 2 months ago in the cancer science. So left side you see the Icaritin to binding to the protein complex, including myeloid-derived and ITK kinase alpha, and downregulating the JAK2 and STAT3 and cytokine, one way to inhibit the tumor cell proliferation. But the most important, the right side, is how this pathway to link to the immunomodulation pathway, including M1, M2, macrophage, MDSC cells, neutrophil, platelets, and multiple immunocell expression, the immune checkpoint inhibitor profiles. So that are the most attractive part of a small molecule. They are not specifically targeting one side, one target, but a modulation, multiple pathways of immunotolerance. This is our first publication of the clinical trial, phase 1. So in year before. So we are more focused on the safety profile of immunomodulation and also investigating of the immunomodulating mechanism and see a little bit few preliminary efficacy in that HCC patients. Here's an example. So we have about 20 patients. We see we don't see much response rate ORR. We see about 18 HBV HCC patients, 1 PR and 5 ST, and 5 to 6 ST, and the rest of others are PD. And you see the top of the picture. You see that PD patient, some of the PD patients with continued treatment, they still see the very substantial benefit to survival. And then most of the SD and the PR, they obviously have a very good response and survival outcome. When we see the bottom of the biomarkers, you see that time we did not design for the pharmacodynamic biomarker, but we retrospectively look at the individual patient. You see the neutrophil changes about 2 weeks before and after treatment. If they decrease the neutrophil, you see the TTP, time to progression, are very significantly higher compared to the increase. And if you use the lymphocyte dynamics, you see that increase in lymphocyte after treatment 2 weeks, and time to progression are very good too. So this is a significant to see the immunocell response to the patient after treatment, and correlated with the time to progression outcome. And this is the case of the partial response rate. The patient are the imaging and CT imaging to see that peritoneal and multiple lymph node metastatic patient after the 8 weeks and 60 weeks and the 32 weeks treatment, you see the tumor given AFP and in interleukin 6 and interleukin 8 and 6 alpha interferon gamma, there are coordinated change during the treatment cycle. This is a phase 2 study, and we just published, as I mentioned, two months ago. So we identified this immunomodulation tolerance regarding ALP, HBV link to the cytokine and the immune cells and the multiple immune checkpoints. And on the 300 days correlating with the biomarker expression pattern, including PD-L1, HBV copy number, alpha, gamma, and new antigen expression. Particularly, I have to emphasize this drug is very, very promising for the patient with poor prognosis, especially if the ALP is high or the HBV-related the Th1 in the cytokine have different profiles. This is our finding of the mechanism of the immunomodulation, as I mentioned, from a right side multiple immunomodulation mechanism, and this is in vivo data to show the treatment of this mice, and to see the downregulating the MDSC population of the immune cell, also downregulating PD-L1 positive MDSC, the population in the mice. And in addition, the different models show the treatment of the Icaritin stimulating the CD8 T-cell infiltration to the tumor tissue in mice. This picture was has a cover page of the European Journal of Immunology. And also we have patient treatment. We see the profile of the TIM3, LAG3, CD28, CD80, and the CTLA4. The baseline and after and before treatment to see the dynamic change of the profile, so well correlated with the survival outcomes. And you see the HBV up panel, you see the higher loading HBV copy number and the link to the interferon gamma and TNF-alpha. However, when you see the bottom panel, to see higher expression in gamma and to show the better prognosis or outcome treatment. And TNF-alpha with a lower expression, we see that even this patient have a very high, very poor prognosis. If the TNF-alpha low, they still have a better chance to have a better survival, up to more than 1 year survival, 389 days of the median OS. For the immune cells, you see the expression of the PD-L1 in the tumor tissue around peritoneal tumor, like a macrophage, the expression higher level, you see the better outcome of the OS. And the left bottom, you see the new antigen pile, you also see the much better survival outcome. While we see that many publications, review papers, we see the immunobiomarker pattern in terms of the retrospective profiling, how we capture the immunosignature of a different pattern of the heterogeneity of the patient. However, this is a kind of a translational study, a very, very less translational to the actionable clinical practice. So we do retrospective study at findings, but in the clinical side of clinical trial, this pattern or signature hard to be deliverable into clinical side. What do we do? Here with the FDA have a clinical guideline to see the clinical biomarker co-development. To see, we do have a concept, but we need an actionable biomarker. And we have to considering how make this biomarker to be deliverable, measurable, and workable, and feasibility to allow the trial design, allow the clinician to find a patient for the better or optimal treatment. We try to build this concept to see composition of biomarker together. We call the LP higher, let's say LP more than 400, and combined with the interleukin 6, 8, 10, on TNF alpha, interferon gamma. We see the multiple scores. To see the score higher, we see the better response, better outcome, and the score lower, 2, we still see the higher, better outcome survival. You see the trend of the scientific concept is consistent. This is we considering maybe this compositive biomarker, the LP with cytokine could be exciting to deliverable to the clinical side. Another way we show the LP plus interleukin 6 TNF alpha or TNF alpha interferon gamma or LP mixed together to make a scoring system to show that a patient have immunoinflammatory status, how able to choose this patient and differentially to with a different drug. And a summary, so our drug is compared to the sorafenib, you see that in terms of safety perspective, we do not have grade 3 and 4 the AE compared to sorafenib. They have more than a quarter of the AE. This is the advantage of our small molecule profile. Now, in addition, this is a small molecule immunomodulation, has oral administration, very convenient, naturally derived, highest accessibility, affordable, less expensive, maybe more accessible for the developing country, for the Asia. And the safety is very good and with very low risk in regarding the clinical management. PD-1 sometimes have management issues with how to handle this hypoprogression, for example, how to avoid the autoimmune or immune disorder patient. HBV is this example. And optimal patient to treat the risk patient, like a high risk patient with a liver dysfunction. And this is another advantage, and easily to adapt to the many different drugs, targeted drugs, and immunotherapy drugs. This is I see that this compound have huge potential in the future. And this is the landscape of the liver cancer or currently in China. We're considering one is the monotherapy, maybe more applied to the trials, phase 3, phase 2. However, in the clinical practice, we're considering combo therapy, even immuno-oncology drugs or immuno-oncology combined with toxic drug, combined with chemo, or immuno-oncology combined with immunoadjuvant therapy. So that is the green color we're considering. However, in the future, we see the precision medicine in the liver cancer or the many other cancers. Still, we are kind of behind of the lung cancer or liquid tumors, but we are moving towards how identify the biomarker actionable and predictable to the different treatment and different time and different patient. So this is we're hoping to move towards that direction. This is my slides. Thank you for your attention, and happy to take questions.
Thank you very much, Dr. Binier. Very, very nice talk. I might start with one question, and then I'll ask people in the chat to ask question as well. So from one of the last slide that you presented with the levels of IL-6 and IL-8 and the way you design a score and match this with response, does that result suggest that you would have higher response rates in early disease versus late disease? Because if I understand correctly, in HCC, early disease has got a more pro-inflammatory phenotype rather than late disease. So do you think that shifting the use of your drug to early disease would lead to better results?
Yeah, a good question. So I could put your question in two parts. So early disease in general are treatable, and the outcome is better than late disease. Okay, so we see the PD-1 trial, we see the Roche their trials. They are more selective towards the early disease, like a CHOP score less than 7. So there are outcome. This is pretty good. So what I see, our score does link to the earlier. If the score higher, the earlier, definitely yes. But we see for the poor prognosis patients, if they are HBV, AFP higher, they also have the TNF-alpha and the interferon gamma, and there are multiple cytokines. For those poor prognosis patients, from clinical perspective, they're hard to project or predict how to make the optimal treatment. They are looking for the scoring system to help them to join their current scoring system to see the better treatment option or management.
Thank you. Ramyashri, you had a question for Dr. Yi?
Yes, as you mentioned, doctor, in the presentation, that combination of the drugs will have a more kind of a response. But my question was like, when you combine two drugs, what would be its efficacies, and will not any kind of a drug becomes resistant? So in that case, how would the patient receives the next over the dose?
Yeah. I see the combination drug. Definitely we have two approaches. One is combination through the trial. Recent study I brief by Roche. You see the combination of VEGFR inhibitor with the PD-1. You see the outstanding outcome. And a well-designed trial. That's the combination. So in the future, we do encouraging all kind of novel drug combined with the approved drug in the trial to see the concept, how far we go. And another way to see the combination is the real-world study. So once the drug approved to the market, see patients and doctors, they have using their experience of practice to do the combination. So we learn a lot from the real world study to see how this combination to make the patient be more beneficial and then lower the risk and increase survival.
Okay, thank you. Thank you for the useful information.